Okay, so let's get into the AV junction. So the AV junction should take over if the SA node fails to initiate the impulse. So the SA node is your first line of pacemaking. Next we jump to the AV, which would be 40 to 60 beats intrinsically. An impulse generated by the AV junction travels down into the ventricles up towards the SA node. So this leads to three possible circumstances in which the QRS complex appears normal. So if the impulse begins moving upward through the atria before the other part enters the ventricles, then you're going to get an upside down P wave. I think this is probably in the other video. But you have the heart, right? The heart's up here, this is the heart, SA node, AV nodes, and then all this is your Purkinje fiber. So electricity is traveling this direction. Honestly, it's more so this direction, but I'm looking at the screen. So it's traveling this way, but if electricity fires back upward, like it's saying back to the AV node, you're going to have a P wave. Instead of it being like this, the electricity is going away from the electrode instead of towards the electrode if you're reading it on an isoelectric line. If the impulse moving through the atria occurs at the exact same time that it travels through the ventricle, the smaller inverted P wave will be hidden within the QRS complex. So your QRS complex, that is when the most electricity is going through the heart because it's going through the biggest part of the heart, the ventricles, and any other electrical activity is going to be hidden or eclipsed by the QRS complex. So you're not going to see the P wave in that instance. If the impulse starts late through the atria, then you'll see the inverted P wave after the QRS complex. That's not a T wave, that would be the P wave. A premature junctional complex is an early complex that appears within another rhythm. So the rate depends on the underlying rhythm if it is irregular. The P wave, if present, will be inverted and may, I need to turn this brightness up. That's as bright as it gets. The P wave is present, will be inverted, either precede the following QRS complex and characterized by the PR interval. If present, less than 0.12 seconds. The QRS complex is going to be nice and tight, 0.11, and can be caused by many of the same factors that cause premature atrial contractions. Does not normally require treatment, and people with the condition are asymptomatic. So you could have perceived skipped beats. It could be lightheaded, could be dizziness, other signs of cardiac output with frequent premature junctional contractions. So frequent PJCs, premature junctional contractions, may be a predictor of future cardiac dysrhythmias. Junctional escape rhythm occurs when the SA node does not function and the AV function takes over. Now it's the pacemaker, also called junctional rhythms. I want to look at this picture. Okay, yeah, we kind of talked about this. I think I'm regurgitating information, but you got your P wave, oh no, it disappeared, P wave. So I think that's what that was bringing home. And then here, I guess it's hidden. Well, this is separate. Okay, AV junction. Junctional escape rhythm. Did I talk about this? Okay, yeah, junctional escape rhythm occurs when the SA node does not function and the AV junction takes over as the pacemaker. So this is also called junctional rhythm. At a rate of 40 to 60 beats per minute, usually regular rhythm with very little variations between the R to R interval. So you're gonna have the rate of 40 to 60, and then the P waves are inverted and present before the QRS, not happening here. The PRI is less than 0.12 seconds, and the QRS complex nice and tight at 0.11 seconds. So this often accompanies an SA node disease. Increased vagal tone could have valvular heart disease, inferior wall myocardial infarction, other conditions, and it can also occur after resuscitation from cardiac arrest. So this is going to be post-cardiac arrest symptoms that patients may have. Treatment depends on the underlying cause, but may require surgically implanted pacemakers. In the field, atropine should be considered, as well as transcutaneous pacing. We're going to use that electricity to pace the patient if they're severely compromised. And I kind of want to go into how to pace, that this is for my benefit. So yeah, And we're going to pace somebody. We're going to get, let's say, the life pack, because we use the life pack. We hook up our pads to them, and then we are going to set to the pace function. And we are going to make sure that we get capture. The point, there's going to be a little line on the ECG, and we're trying to get that line as close to the QRS complex as possible. Most likely it's going to be right at the negative, or I don't know if it's negative or if it's positive, but it's 70 millivolts. It'll say that on the life pack. You're going to crank it till it gets to about 70 millivolts, and if the line is still not at the QRS, we're going to turn it a little bit more until we're lined up and we're locked in, and then at that point we're going to hit pace, and it's going to send electrical activity through the pads to pace for us to the patient. And then if we're not getting enough of a pulse, then we're going to up the amplitude, the amps as well, so we can adjust that. And I can't even remember what the number is. I think I'm not even going to say. Okay, so accelerated junctional rhythm is present with a rate exceeding 60 beats per minute, but less than 100 beats per minute. So we're not at tachycardia yet, because tachycardia is over 100 beats per minute, but we're accelerating there. So accelerated junctional rhythm. Regular rhythm with a little variation between the RR intervals and the P waves. If present, it is inverted or upside down before or after the QRS complex. It's characterized by a PRI of less than 0.12 seconds. May be associated with digoxin toxicity, could be hypoxia, inferior wall MI, rheumatic fever, recent cardiac surgery, and electrolyte imbalance. The patient usually is asymptomatic. I kind of want to look at rheumatic fever because I'm not even sure what that is. Junctional tachycardia accompanied by a rate that exceeds 100 beats per minute. So now we're at junctional tachycardia, we're over 100. ECG characteristics are the same as accelerated junctional rhythm, but the rate is faster than 100 beats per minute. It is uncommon in adults, but associated with acute coronary syndrome, heart failure, theophylline administration, or digoxin toxicity. I want to look that up, theophylline. Okay, at a rapid ventricular rate, distinguishing junctional tachycardia from other narrow QRS tachycardias is often difficult. If the patient is symptomatic, then treat accordance to the tachycardia algorithm. Let's stop right there because I'm going to look up those two things, rheumatic fever